Good morning. I'm Christine Vaglienti. I'm litigation counsel for the hospital, and I'm here to talk to you today about informed consent. I admire all of you right off the bat. I could never do what you do because I could never get up this early every day of my life. Um, I'm not going to go through all of these slides individually with you all. This presentation was originally created for the nursing staff. But every time I do this presentation for the nursing staff, they always say to me, do the doctors hear this information too? So we're going to emphasize some of the things that are more particular for physicians. I'm very happy to take questions during the presentation, or you can save them to the end if you want to do that. I also have with me Joe Smentana. He is the risk manager for the hospital, and he's going to finish us up today with some additional information about informed consent and how it really affects litigation. So the things I'm going to tell you today are not just made up or pulled out of thin air. These are the policies that kind of guide informed consent. And with respect to some of the information I'm going to share, there's actually case law in West Virginia going back to the 1990s that talk about informed consent. Informed consent is defined as the voluntary authorization of a medical procedure or treatment by a patient who has been provided with the relevant information by his or her physician. So even though this is referenced in a policy, this is actually a statement from the case law that I referenced that makes the responsibility for informed consent fall on the physician. These are the people who can give consent: an adult with decision-making capacity, an emancipated minor, a mature minor, a parent or guardian for a minor child, or someone who has medical power of attorney or is a healthcare surrogate for an adult patient who does not have decision-making capacity. Sometimes you will hear a parent or a grandparent or say something like, well, I'm the MPOA for my child. There's no such thing. A child does not have a medical power of attorney or a healthcare surrogate. They have a parent or a guardian. Only an adult who lacks decision-making capacity can have a medical power of attorney or a healthcare surrogate. In West Virginia, and this is defined differently based on the state that you're working in, but in West Virginia, there are only two ways that a minor can be emancipated. Either they're married or the court says they're emancipated. So it's really kind of a weird glitch in West Virginia. I can be a 16-year-old unmarried woman with a baby. I can give consent for my baby to have a circumcision, but technically I can't give consent for myself to have a C-section unless the doctor determines that I'm a mature minor. So a mature minor is a little bit different than an emancipated minor. A mature minor is someone who has been determined by a physician to have decision-making capacity almost equivalent to an adult. They can understand the risk and benefits, they can ask relevant questions, and they can make an informed decision about their health care. So obviously, if you make that decision with a minor that you think they are mature and can give consent themselves, you need to be very careful about documenting that and kind of how you came to that conclusion. The same thing with an emancipated minor. You need to have documented that they're either married and therefore emancipated, or they have some court paperwork that shows that they have been emancipated by the court. When you're talking about parents or guardians for a child, you do not have to have the consent of both parents. The consent of either parent will work. And it's really not our job to get in the middle of parents who might be disagreeing. Care management is often brought in to help figure out those kinds of issues and who has been granted authority from the court to make decisions on behalf of a on behalf of a child. It's usually the parent who has primary custody, but not always. And if you have any concerns or questions about that, you can always get legal services involved, and we will help run that down too. Obviously, in an acute or an emergent situation, if you can talk to one parent and get their consent, you're good. And in an emergency situation, you don't even need that. If it's a matter of saving life or limb, you can go forward without consent. But you do have to follow up then afterwards and give at least information to the parent or guardian about the surgery that's been done. To invoke a medical power of attorney or a healthcare surrogate, the adult patient has to lack decision-making capacity. Again, decision-making capacity is determined by a physician. It can also be determined by a physician assistant or a nurse practitioner. A lot of times you'll have patients, maybe older patients or patients who maybe aren't as assertive, who will say, oh, well, my daughter is my health surrogate. She can just make the decision. But, you know, if the patient has decision-making capacity herself, she should really be involved in the informed consent discussion, signing consent forms, that sort of thing. She can't just turn it over to the daughter because she wants to. The daughter can obviously be there. The daughter can ask questions. The daughter can advise her mom, but really it should be the patient who's making the decision and signing forms. Decision-making capacity, as I said, can be held by someone, obviously, who's an adult. A mature minor can have decision-making capacity, or an emancipated minor can have decision-making capacity. And decision-making capacity means that they're able to understand the nature, risk, and consequences of a proposed treatment and alternatives. They're able to reason and deliberate about choices, and they're able to communicate their decision to the attending physician unambiguously. So if you've designated someone to be a mature minor, but they can't go through all of these steps, then you're probably needing to refer back to a parent or a guardian to make a decision. If you have an emancipated minor, maybe they're, 17 and married, but they can't go through these steps, then they probably can't be deemed to have decision-making capacity, and you'll have to find someone else to participate in the informed consent decision. Mental patients and prison inmates who have decision-making capacity can give consent. And there have been some real touchy situations that I've been involved in before where prison guards or maybe the prison warden has wanted to make medical decisions on behalf of an inmate who is a patient here. And that simply is not appropriate. Technically, what is supposed to happen when an inmate comes into the prison system is they are supposed to be given the opportunity to designate a medical power of attorney. A lot of times what happens is the prison guards and the prison officials are uncomfortable with providing that information to us because they see it as a security risk if the inmate's brother in Michigan knows that the patient is here in West Virginia, that can create a security risk. So we often have to do this dance with the prison officials to get the information we need to get consent on behalf of an inmate who does not have decision-making capacity. And unfortunately, sometimes the prison officials, especially the ones who are here on site, can be pretty intimidating, especially to nursing staff. And it makes things kind of difficult. But again, if you have those kind of problems, let us know in legal services and we can help you through that. The same thing with patients who have some kind of a mental disability. You could have a fairly high functioning patient who had some kind of mental disability. And as long as they could go through those steps that we talked about that determine decision-making capacity, they can make decisions for themselves. But if you have someone who has a very severe mental disability and can't go through those steps, then you're going to need to have a medical power of attorney or a healthcare surrogate or a guardian who makes the informed consent decisions for them. This is another policy that is written with case law in mind. The physician has the responsibility of properly informing the patient about the nature of an operation, any associated risk and alternative treatment methods. Obtaining consent is the legal responsibility of the physician, and it cannot be the responsibility of nursing staff or any non-physician employee of WVUH. I think this statement in policy is what gives nurses heartburn and why they sometimes police physicians so hard about informed consent. But what I try to explain to them is informed consent is not that document that gets signed right before you walk back into the OR. Informed consent is the process of exchanging information. And the example that I always use is from my own experience. I had to have a knee replacement, but I did not want to have a knee replacement. So for 2 years before I had a knee replacement, I did everything and anything I could do to avoid it. So by the time we got to the knee replacement, my doctor had already talked me through physical therapy, injections, all the alternatives, the partial knee replacement, the full knee replacement. And there's no way that a nurse was present for every single one of those conversations over a 2-year period of time. But that exchange of information was really the informed consent that my doctor was giving me all along. So by the time we got to signing the form, it really was more of a formality because that exchange of information, which had all happened in an outpatient setting, was complete by that time. And I didn't go back and read my medical records, but I'm sure each time my doctor, put in the office notes, talk to this lady about injections, talk to this lady about physical therapy. And so the informed consent, as I said, was more of a process. It's not just the documentation. Now, the documentation is extremely important because that's what can be audited by OFLAC or Joint Commission. That's what is used for the timeout before surgery. So I'm not trying to undermine or undervalue the importance of the documentation. But what I am trying to explain to you is that informed consent is not a one-time thing that happens immediately before a surgery. It can be a process, especially when a person has a more chronic condition and you're kind of working up to surgery along with other treatments that you've tried. The attending physician can delegate the facilitation of documentation and the explanation of informed consent to any qualified personnel. Where 2 or more providers perform different procedures on one patient, each should obtain separate informed consent. So there's absolutely nothing wrong with the attending physician saying to a resident or saying to a physician assistant, you go have the conversation with Mrs. Vaglienti about having her knee replacement. You've been through this before, you know what the risk and benefits are, you know what the alternatives are, explain all that to her, and then have her sign the form. Ultimately, what's going to happen is the attending surgeon has to sign the form too, but the resident or the PA or the nurse practitioner can have the conversation. The attending physician still maintains legal responsibility for the content of that conversation. So if for some reason the attending hasn't properly educated the PA about all the risk and benefits, then maybe that could be a basis for liability, but delegating is appropriate. If you're going to have an anesthesiologist and a surgeon, that's the most common thing, then they both need to obtain informed consent. But let's say you're going to have some really complicated surgery where you have an oral surgeon and a plastic surgeon involved, and they're doing different parts of a procedure. They should each do an informed consent for their part of the procedure as well. After the procedure's been explained, the physician shall sign the form. If it's been explained by a PA, the PA can sign the form, but ultimately the attending has to sign the form. And, you know, that I think sometimes is a point of contention because it can slow things down. But ultimately, by our policy, the attending does have to sign the form. Because we want everybody to be sure that the form itself, which is used for timeout, is accurate with respect to the procedure that's going to be performed, laterality, and all that kind of stuff. Witnessing a consent form doesn't really apply to you. This is usually done by a nurse, but this is where nurses get very nervous because they think, if I didn't hear what the doctor said to the patient in the office, then how can I witness this consent form? They're not witnessing the content or the quality of the conversation. They're just simply witnessing that the physician spoke to the patient, which they can ask the patient about, that the patient gave consent, that they were given the opportunity to ask questions, and that their questions were answered fully. And that's really all witnessing means. If they weren't present for the informed consent discussion, they ask the patient those questions. If the patient answers those questions, yes, then they can witness the consent form. If the patient has any questions, the nurses should not try to answer them. They should get the anesthesiologist if it's an anesthesia question. They should get the surgeon or the resident if it's a surgery question. And then once those questions are answered, they can witness the consent form. That's more for the witnessing. What if the patient asks nurses questions about the procedure? Again, nurses are instructed not to answer the questions. Those are for the physicians. If patient is a child and the parents don't agree, again, we talked a little bit about that. You don't have to have the consent of both parents. If parents are disagreeing, you can ask legal services to get involved, or you can ask care management to get involved. We can help track down some of the legal documentation that may say which parent, you know, gets to be the tiebreaker. If you have a patient who's a child and the parents aren't available, again, care management or legal services can help in that dilemma. If it's an emergency, it doesn't matter. Sometimes parents will have designated someone who can make a decision on behalf of their child if they're absent. That happens a lot when you have military parents, when you have incarcerated parents. Sometimes DHHR is involved, and they have to be the entity that gives consent on behalf of a child who is in their custody. Sometimes DHHR will permit a grandparent or a foster parent to give consent, but ultimately DHHR is informed of that. And again, that happens kind of behind the scenes. Care management takes care of that. What if a surgeon wants or needs to do additional surgery? So you've consented the patient for a surgery, and then within a few hours, you have to take the patient back to surgery. Do you have to go through the whole informed consent process and get a new informed consent form each time? No, you don't. Our policy is very clear that as long as the risks of the second surgery don't differ materially from the risks of the first surgery, you can go with the first informed consent form. Now, if going into the first surgery, you know this is going to be a series of surgeries, your informed consent form should say this is going to be a series and the patient actually consents to the series. But sometimes you don't know that ahead of time. Sometimes something happens after you've brought the patient out of the OR when you have to take them back. You're really going back to address a complication or to address a change in the patient's condition that wasn't anticipated. And as long as the risks have not changed materially, you don't have to go through a whole new informed consent form. If something has changed and it's really now much more risky to do the second surgery than the first, then you should try to reach a healthcare surrogate or a medical power of attorney and go through an informed consent discussion if you can. What if a consent signed by a patient or the representative is old? This is a concern also that nurses have. The informed consent forms don't really time out. They don't like expire after 3 months or anything. It again goes back to have the risk of the surgery changed materially. Now, I don't think it's a bad idea just from protecting yourselves to do note in the record that says, you know, had informed consent with discussion with patient 3 months ago, nothing has materially changed. That's just going to cover you that you at least thought about it and you are acknowledging that nothing has changed so that you don't need a new consent form. But the consent form that maybe they signed in your office 3 months before should still be good if nothing material has changed about the risks. I'm not going to go through these no CPR ones. This is probably the one that's the most significant to you. Even if the patient has a no CPR order, it's presumed that that will be suspended while the patient is in the OR and the PACU, and then it'll be reinstated once the patient returns to his or her regular unit. Now, that's the presumption, but a patient can override that presumption. They can say, look, if something happens while I'm in the OR, I don't want to be resuscitated. That should be very well documented because it is contrary to policy, but that is the presumption with a no CPR order. Yes.
So, run into that a lot, and I think it's reasonable to think that particularly if there's no terminal outcome or when there, you know, something does happen, please don't do that.
Mm-hmm.
So what else do you try just try to do? And everyone just says, no, you can't do it, or they tell you you have to.
Who?
Yeah, so how do we get around that? Fix that? That's a big deal.
Well, if it's Dr. Duda just said it's anesthesia who takes that position, and that's really like their mantra, that, you know, while they are controlling the patient's bodily functions, they are controlling the patient's bodily functions. I would say it probably takes more of a conversation with anesthesia and you and the patient. So anesthesia understands that's what the patient wants. I mean, technically, the patient's wishes should control, not anesthesia's, you know, regular mode of operating. But that's what I think it probably takes, is more than a note, is them having the conversation as well and being able to document their participation in that conversation.
That is the.
Hold on, I'm gonna look at it.
You know, that's a good question. I will look at that when I get back to the office and I'll email you.
That would give us power as surgeons.
Yeah.
Have that discussion with the family, and the patient, that if they choose this, that we can say the anesthesia will they can choose this,
Okay.
and then have the production.
All right, I will go back and look at the policy, and if I find that, I will send it to you so you can distribute it. Okay. Medical power of attorney is someone over the age of 18 designated by the patient to make healthcare decisions for the patient if he or she is unable to do so. So this is a legal document. Even though we are in West Virginia, if a patient brings a medical power of attorney document from Maryland and it doesn't look exactly like our West Virginia medical power of attorney document, we are still going to honor it. There are slight differences. You know, one state may say it has to be witnessed by 2 people and notarized. Another state may say it has to be witnessed by 1 person and not notarized. But again, as long as the patient's wishes and designation are clear, we're going to do anything and everything we can to honor it. We can also rely on the MPOA, even if you have family who's kind of sniping each other and saying, you know, mom wouldn't want that or dad wouldn't want that. But the MPOA says, oh yeah, I've talked to dad and dad really does want that. And I'm the MPOA. You can rely on that. Again, if you get into those kind of issues and concerns with a family and you need us to get involved, just let us know and we'll be happy to do that. Patient advocates are also a good resource to help you navigate those kind of family issues as well. A surrogate is what is used when the patient has not designated someone ahead of time to make medical decisions for them. Again, care management usually helps with this process for choosing someone. Ultimately, the way the statute and our policy is written, the choice is made by the physician. But the documentation of the choice is facilitated by care management. A surrogate should be someone who's reasonably available. Doesn't necessarily mean they have to be physically available, but if you're choosing between a son who is here in Morgantown and can have face-to-face conversations with you, and a son who is in Michigan and is only going to be able to talk to you by phone, it's appropriate for you to choose as the surrogate the son in West Virginia, if you think that being able to have that face-to-face communication is significant to helping you make decisions for the patient.
Let me look at it.
To be someone who's willing to make healthcare decisions on behalf of an incapacitated patient. The statute that talks about surrogates kind of gives you an order of people that you're supposed to go through. So for like me, you would go to my husband first, then you would go to my adult children. But if my husband himself were incapacitated or just didn't want to serve in that role, then you could go to the next person on the list who was willing to serve.
Okay.
They have to have the capacity to make healthcare decisions for the
I
patient.
don't know what language it is.
Okay. So again, if the first person on the list maybe has very low health literacy, but somebody else on the list would be better suited, then you can go with that person. Whether you're a medical power of attorney or healthcare surrogate, your authority to make decisions does not begin until the patient loses decision-making capacity. And decision-making capacity can be a fluid thing. So one day I could have decision-making capacity. I could be in that state for a few days, and then, you know, when anesthesia wears off or when I'm not septic anymore or whatever the case may be, I may regain decision-making capacity. When that happens, the medical power of attorney or the surrogate no longer has authority to make decisions for me. It's back to me making decisions for myself. Once the patient passes away, the medical power of attorney or the surrogate no longer have authority to make decisions, except they can make decisions about burial and about autopsy, and they can request copies of patient medical records, but that's all they can do. They can't make any other decisions. So like organ donation, if my driver's license says I'm an organ donor, the medical power of attorney can't say, no, she's not an organ donor. So they can't make those kind of decisions.
You know, the driver's license, are they able to?
Then they're able to, yes. but they can't override a decision I've already made.
So, sorry about this.
That's okay.
So I have a real issue because what happens with the DOT is not actually. So you walk in and they say, you know, you want to be an organ donor. Or like, oh, I gotta get my things done. I gotta get on a plane. Right? And then it's discussed of what it then it becomes a very contentious issue. And you have patients easy when they're breaking. It is not easy when it's kind of close to end of life, but not really end of life. The patient's a lot. And then for users that check on the back of the driver's license, and they say, well, no matter what, you have to keep going, and they will go for it.
What's DCD?
So that means the patient at the operating room, wow, we then passively extubate them and let them die in the operating room. And then 2 minutes after circulation stops, the harvest team comes in and takes the organ. So it can be done very, very well. It can be done very, very hospitally, especially when Ford is telling a family who's not yet. He says, Bob would not want to do all this. My child would not want to do all this. I just want to comfort them. I don't want to put them through anymore. Ford says, well, no, you have to because they said they want to be an organ donor, and you're not even really going to be able to switch them at the end of life.
I mean, I'm familiar with that scenario because I've heard about it before, but I can't say that I've actually done legal research about just saying no to core and then what happens. I suppose they would have to go to court to, make us do something we didn't want to do or make a family do something they didn't want to do. I don't know. It's never gotten that far in my experience.
You might want to look at that because what they do is they
Bully.
fully or just tell them.
Yeah.
And in fact, you're just it's awful.
Well, that's not.
Oh no, it's awful and ugly and it's terrible.
Yeah. Well, yeah. Well, nobody's going to go to jail. That's silly. But yeah, I will look at that. I'll assign one of our attorneys to do some research into that and see like what the actual legal steps would be when they're threatening those kind of things. Right. Right. Okay. Okay. Incapacity and decision-making capacity, we talked about before, is determined by a physician. By statute now, it can also be determined by a nurse practitioner or a physician assistant, and you can't just presume it based on age or disability. Medical powers of attorney and healthcare surrogates have the same right of access to medical information as the patient. They have the same right to discuss medical information with providers as a patient. This is captured in policy, but it's also the language in a statute in West Virginia. We already talked about children don't have medical powers of attorney or healthcare surrogates. Those terms only apply to adults. These are some questions and answers. I'm going to go through these real quick. Who's responsible for the information contained in a consent form? Attending physician, that's right. And then here's the policy that says that. Who can sign a consent form as a witness? has to be an employee of a hospital. So you can't have the patient's daughter or the patient's boyfriend witness the consent form because they wouldn't know these 4 questions to ask per policy. Only a hospital employee would know that. Can a patient who's confused sign a consent form? That kind of depends on the depth and nature of their confusion. In policy, okay, because I know sometimes you guys get pushback on this. They'll say, well, we've already medicated the patient. They can't witness their consent form. Right here in policy, it says, not every patient who receives a medication is confused or lacks capacity to make healthcare decisions. So, you know, it just kind of depends on if you gave me a Versed 10 minutes later, you don't want me signing anything. But, you know, there are people who, you know, are bigger than me or, you know, take other kinds of medications that if you gave them a Versed, they'd be fine. And they could sign their consent form. So it kind of depends on the patient themselves about their reaction to the medication and are they still able to understand what you're telling them, ask questions, reason, and make decisions. Does the surgeon have to sign the consent form? Yes, ultimately they do. Even if other people have been involved in the documentation of the consent, ultimately the surgeon has to sign. Can a single consent cover multiple bringbacks to the OR? Yes, depending on the situation. If the material risks of the procedure have not changed, you can rely on the same consent form. The other thing I would say is it also depends on the nature of the information in the consent form. If you're actually, you know, if you went in originally and you did surgery on the patient's left leg, but now you have to go in and you have to do surgery on the patient's right leg, you probably do need a new consent form because the laterality has changed and that's going to affect your timeout procedure. But if you're just going back in to do surgery on the same leg and the risks are the same, you could rely on the same consent form. Can an anesthesia resident sign a consent form? Yes, they can, and they can participate in the consent discussion, but ultimately the attending anesthesiologist has to sign. And this is just quotes from the policy about that. Who can sign a consent or give informed consent for a patient who's a prisoner? They should have a medical power of attorney or a healthcare surrogate if they lack decision-making capacity. If they have decision-making capacity, they can sign for themselves. If the parents are unavailable, who can sign? Again, you find someone who's been designated as a guardian. Sometimes that's going to be an agency like DHHR. Sometimes it's going to be someone who the parents have designated. And you want to document, or care management or nursing is going to document how you came about finding that person who is able to sign the consent form for the child. These are incorrect counts. These are about nursing. But, you know, nurses are supposed to tell you when a count is incorrect and, you know, stop the procedure and let you make the decision about, you know, looking for it. If you don't find it, do you need an x-ray? If you get an x-ray, you wait to have the x-ray read, and then they document, document all of that in the record as to why the count was off and what was done about it. This is a question that's kind of universal. If you have patient safety concerns and you want to have them addressed in a way that is protected and privileged so that it can't be discovered in a lawsuit, is there a way for you to do that? And yes, you can do that by using this pswp.wvmedicine.org email. PSWP stands for Patient Safety Work Product, and that information goes into a protected email that keeps things confidential, but then this patient safety department has the information and can work on a response. You can also make anonymous reports to the compliance hotline at either a phone number or there's a email as well that you can use. Any questions for me before I turn it over to Joe? Yes.
So for a medical power of attorney where, they have to.
Yes.
So like if you do that, very active. That's not the appropriate.
That's not the appropriate release of information, but as long as the patient has decision-making capacity, they can designate that person as a surrogate or I can't remember, a proxy for their MyChart information, and they can have access that way. So there are ways for the patient to permit access, but just someone coming in and saying, I'm the MPOA and I want copies of their medical records, that's not appropriate.
Or if they, is calling and asking for information about the patient.
Correct. If the patient has decision-making capacity, then you should really be talking to the patient. Now, the patient could say to you, look, family doctor, or look, surgeon, my daughter's helping me make decisions. I want you to be able to communicate with her, just like I could bring my husband with me to my appointments and say, please feel free to discuss with him too. That's okay, but that's because the patient has given you specific permission, not just because this person is saying, I'm the MPOA and I demand it. Yes.
Thank you. Also, there are certain circumstances where in our group practice, on Sunday, one of us can take a patient for a treatment. Then remains unchanged. Go back the following day. That second surgeon also designed that. Also, we have multiple occasions where it says different every time that the operating every day, 7 days in a row. So it's different.
Interesting. Yeah, I mean, that's not really what the policy says. I can see from a hypervigilant liability perspective, I could see why anesthesia would take that position. But I think if your informed consent says, because I've seen informed consents that will say Dr. Schaefer or his associates, or Dr. Schaefer or, / surgeons in Department of Surgery. I think that should be sufficient, especially if you're telling the patient up front, this is going to be a series and it won't be the same person every single day. And to even cover yourself more, you could make, when you do your informed consent note, you could say, explain to patient, this will be a series and it may not be the same surgeon every day. Then it's clear you've had that conversation with the patient. It sounds to me like anesthesia is being much more literal and much more just careful about the liability part of it. But I guess that's their choice, but I don't know that it's absolutely necessary per policy. Any other questions? Okay, I'm going to turn it over to Joe. Thank you very much.
Well, good morning. My name is Joe Smetana. I'm the Director of Risk Management, and a little bit about me. I've been here just over 2 years, and my academic experience previous was with Indiana University Health. I was a Director of Risk there. And I report up to Chris in legal, so that's where I'm housed, is in the legal function. I'm a department of 2. It's myself and over here, Lisa Wishner. And we make up the risk management department. We partner with quality, Dr. Settle and her team, and of course with legal. So that's how we fit in. And I just want to go through a couple things here. The data I'm using here is MedPro, which is a large, probably one of the largest physician health insurers. And Harvard University put together and analyzed data on informed consent liability and claims that they've seen. And what they found is that surgical invasive procedures involving skin biopsies, total hip replacement, but no single procedure, there's not one single procedure that accounts for claims regarding informed consent. 60% of the cases involve inadequate informed consent originally in outpatient area. So when you look at inadequate consent details, 71% is falls under that area. That's where a lot of those are, those claims. Most common locations of physician's office, clinic, 25% is pretty much spread across the board where we have claims regarding informed consent. Very much, pretty much the same there. Lowest is, they do have, MedPro offers insurance to dentists too. That's why the dental information is there. So the intersection of events to informed consent, rarely there's just one underlying risk factor behind adverse patient outcomes. Cases involving inadequate informed consent are no different. And so 51% of them, the selection of most appropriate procedure, and then recognition management of known complications is another factor that plays into liability, and the known complications pop up. I just thought I'd take a moment for a quick education on, there's a test that can be used for known complications. And basically there's, if you answer no to any of these questions, was a procedure, treatment, or test appropriate and warranted based on recognized standards of care? Was the complication a known risk? Was it anticipated? And did the care team plan ahead to take steps to prevent the complication? So when you look at known complications, all these elements must be addressed. Was the complication identified in a timely manner? And was the complication treated according to standard of care? As long as you answer yes to that, it's a known complication then. So I looked back at Ruby's EMS reports, which is our incident reports on informed consent and incidents that we're seeing. I don't have an exact N, but we're looking at wrong procedures, wrong sided documentation, wrong levels, consent not available at the time of procedure, wrong patient, and the form not signed. We get a lot of those that the form wasn't signed. I would say that's the most prevalent EMS report that we get. Current deficiencies with the informed consent process. Patients believe that the purpose of the informed consent is for a hospital to protect. They see it as a liability tool for the hospital and physicians to prevent liability instead of what it should be as a conversation about the planned medical procedure. Patients report feeling that they didn't have a choice about the medical, whether to sign the consent form or not. I'm sure you have sometimes that difficult conversation between a patient and yourself that they feel like, oh, you got to make sure that there's clarity around the informed consent process when you meet with the patient, that they do have a choice, as Chris had talked about earlier. The informed consent is a conversation. It's a key component of patient-centered medicine, a concept that emphasizes importance of patient actively participating in their care. It's a patient right, as Chris had talked about, that they have a right to decide on the procedure or not. And that's an important element. Next year, you're going to be seeing a lot of education coming out on disclosure of medical errors and things like that. And, they talk about, we do the informed consent. We tell patients exactly what we'll be doing, but when something goes wrong, we don't always disclose that. And we're going to try to work on the culture to change that a little bit to make sure that we're disclosing medical errors. An accurate informed consent form is essential to patient safety. Chris touched on this too, but I want to emphasize the form is important, like she said, for the timeout procedure. The timeout needs to match the consent form. What's said in there, what the planned procedure is, needs to match the form, what's on that form. This is what we're doing. I think you typically read the informed consent. This is the procedure that we're gonna do. So everybody's on board, what the procedure is and what we're gonna be doing. So it's important, it's essential to patient safety. What can be done to improve? This, some suggestions that came out of this study that, they had was, create a checklist that's designed to be used before a procedure when you haven't met the patient. I know, we talked about a lot of these, you know the patient, but a lot of times you don't know the patients, right? So it's good to go through a checklist of what you're going to say as far as risk, benefits, and alternatives with a patient you don't know, to make sure you get all the things done appropriately and check it off. Focus the checklist on consent conversation, not the form. Interventions that enhance the conversational aspects of informed consent are more effective at improving patient understanding. Communicate by synthesizing and simplifying complex medical information, balanced manner that is meaningful to patients. Sometimes we have to understand that some of our patients have sixth grade level education. We need to make sure that they fully understand what the procedure is in simplified terms. Sometimes we get into our medical terms and we got to make sure that we simplify it as much as possible. So we ensure that they have good understanding. Lastly, communicate risk, benefits, and alternatives. That's all I have. I just want to mention a couple things. I recently put a couple documents in the Epic. Epic has a reference section. I'm not sure exactly where that is, but there is a reference section for physicians of things you need to know and to refer to. I recently put two things in there as references. One is a medical error disclosure tip sheet to give you tips on what to do if you're questioning if you need to do a medical error disclosure. That tip sheet is there, gives you advice on how to do it, who needs to be there, and who needs to be contacted. And the second thing I put in there is a information on autopsies. I'm finding that in West Virginia, the medical examiner does not always take cases. I know they're 9 months behind in completing reports. So they're really pushing back on doing medical. But sometimes we have medical events that occur that sometimes it's really helpful to have an autopsy. And I talked to our pathology folks and the residents, and they don't have enough autopsies. They're really hoping that we can start producing more autopsies for them. So there's a tip sheet on that, a reference in that Epic reference manual. I want you to be aware of that. So if you ever have a question about it, the hospital pays for an autopsy. So the patient and family is not responsible for that bill. So we offer that for free. And we're a learning organization. We need to learn, what actually happened here. And I think it's important. Chris?
I think part of the information that's in the autopsy tip sheet is we will pay for an autopsy on any patient from any West Virginia University Health System facility. So if a patient expires at Reynolds Memorial Hospital, they can come here for the autopsy. And the medical power of attorney and a healthcare surrogate can consent for a patient to have an autopsy unless the patient's medical power of attorney documentation says, I do not want one.
And our Chris supports autopsies. She supports that we do them when you don't know, right? I mean, it's better that we do the autopsy from a legal liability standpoint. I'm talking about too, that it's better to know what the cause of death was than not know. It's much easier sometimes to go into litigation. And if we did wrong, we did wrong. And, then we deal with that. Hi, doctor. Yes.
That's fantastic. We've struggled with this for 50 years. So does the patient have to just be the subject of a potential safety report to have the autopsy? Because this has been a huge barrier. And I'll tell you, this information is not known to anybody. But what we end up counseling, what end up people get told is that we could get you, if the ME declines it, we could get you access to the autopsy. You're going to pay for it. That's usually a barrier. Families can't afford it.
Right. Right.
So does it have to be under a
No.
safety guise or anything, or is it a thing for our medical education to help us?
No, it does not need to be a safety event. It's whenever you believe You don't know the cause of death, and it's a learning opportunity, but not even just liability.
Or the family request.
Or a family requests it,
The family request can be honored.
yes.
Yeah.
If you agree to it.
Yeah, yeah,
The
yeah.
physician needs to approve it, is all, that's all.
So we need to get that message out really,
I,
really
I'll-
wide.
I'll send the information to Dr. Rita so she can, distribute it to all of you.
We can do it as an EduBlast to go through all of CCTI if you want, because that's
We can
often.
do that,
Yeah.
but the other thing, we need to make sure, we need to get it to hospital administration, nursing leadership,
Right.
and then also scholar.
yeah,
Well,
no, I agree, Dr.
pathology's the
Wilson.
one who wants it.
Yeah, they
so
want it, they want it.
know.
They don't have enough for their students to do, is what they told me.
That's been a chronic problem for
Yeah.
a long time.
And I see the numbers and I know we're not doing enough. You know, again, I worked at other facilities. We don't do a lot here. We need to increase that number.
Well, from a trauma standpoint, it would help us a lot. We have a lot of patients that, we have less than 2% of patients that don't survive and they get here alive. So,
Right.
Reality out there is good. When we do have a patient that dies very quickly, oftentimes we don't have the opportunity to scan, particularly for a young person, it's really nice to be able to know
Right.
what their injuries were.
Right.
And to be able to tell kids.
Yeah, everyone supports it, legal to, when in doubt, do one, if the family agrees.
And I think part of it has to do, with the change in leadership in pathology. The chronic problem that you were discussing, I know exactly what you, but I think there's an attitude change in the Department of Pathology.
But it all came down to money. They wanted to do it, but they had to have the money. So if somebody's willing to pay for it.
Yeah. They did say to me, you know, well, if it gets crazy, well, you know, if we get too many, but that's never happened. So, you know, there's gonna be a balance at some point if we get one a day or something like that, but I don't foresee that happening. You know, I think we just need to promote it.
So there's still a separate consent process.
I believe there's a form.
There is a form that
Yeah.
has to be completed, giving.
That's in the tip sheet. The tip sheet offers, you know, the reasons we want to do things, on content. Okay,
Thank you very much.
thank you very much.